Hi guys, Dr. Gillard here again. This is the last, as I just said, this is the last lecture for the fall of 2020 for cardiovascular and pulmonary pathology class. We're talking about the common lung diseases today. It's Thursday, it's week 10. Here we go. Now, I took a lot of slides out so I could get more pathology in here. Did this actually last quarter. I would strongly recommend you go to my main YouTube page, go to that link, and watch this video. If you're shaky with your anatomy and histology of the lung tissue, it will make this lecture go better if you watch this one first. I'm not going to test you on this one this quarter, though. All right, obstructive lung disease is a main category. Sometimes Robbins calls it airway disease. It's a main category or an umbrella term that has conditions underneath it. And all of these conditions have one thing in common. It means that something blocks the flow of air through the tracheobronchial tree. The blockage could be complete. It could be a partial blockage. So typically, they progress breathing difficulties, right? If your tracheobronchial tree is blocked from whatever, you have trouble breathing, right? And it could get so bad where you have trouble with things like acidosis and even oxygenating the body tissue. So you could die from this condition. Another important thing before we start is get rolling here. Obstructive lung disease versus restrictive pulmonary disease. These are not AKAs for each other. RPD occurs when something reduces the ability of the lung to expand. So it's got nothing to do with something blocking the pipes or the airway. These patients, by the way, we talked about in lab, diaphragmatic excursion tests. These people will have decreased diaphragmatic excursion. Right? What are examples of RPD? Severe scoliosis, right? Scheuermann's disease, or just getting old, osteoporosis, and severe scoliosis can compress lung tissue to the point you don't have not much functioning lung tissue anymore. Obesity, severe obesity, polio used to do this. Interstitial fibrosis, pneumoconiosis. These are all examples of restrictive pulmonary disease. So back to old obstructive lung disease. Some stats on it. It's the second most common cause of permanent disability in the USA. The first is heart disease. The world prevalence is about 16%. Let me say that again. The world prevalence by some researchers has been seen to be at 16%. It's not as high in our country, but that is a huge number. Mortality rate is also on the rise from this, even though we're getting better at treating it. So it's another one of those, is it something in the environment? What's going on? We don't know for sure. Subcategorizing old has been challenging because diseases, especially 3 diseases, overlap. So here's the main subcategories of obstructive lung disease. COPD, chronic obstructive pulmonary disease, it's not an AKA for obstructive lung disease. It's one of the subcategories of obstructive lung disease. And as I've said a few times already, chronic pulmonary or chronic obstructive pulmonary disease, or COPD, has itself 2 subcategories, emphysema and chronic bronchitis. And some authors, more and more authors, are including chronic asthma in there as well, because chronic asthma can also scar up the microcirculation of the lungs and put stress on the right heart and cause pulmonary hypertension. So it really should be included. Rubens and Robbins don't, and those are chiropractic board books. Well, that's where board questions come from, so I'll leave it at that for this lecture. Bronchiectasis is another cause of old. Chronic tracheal obstruction Maybe you have a congenitally narrowed trachea and it's building up, or you have a condition that deposits scar tissue in the lumen of the tracheobronchial tree. That could do it. Chronic bronchial obstruction. So those are all members. Nice, easy one for me to make a question from, huh? One thing in common, all people with obstructive lung disease have airway obstruction. I mean, that's kind of intuitive. There's 3 different mechanisms for the cause of this obstruction, very similar to small bowel obstruction. You can have a problem inside the lumen of the tracheobronchial tree, a problem in the wall of the tracheobronchial tree, or a problem outside the wall that's pushing and compressing the pipe. All right, nice little slide here. So here's an example of problem inside the lumen. People with chronic bronchitis. I mean, sometimes they have both of these problems going on, but so mucus or fluid, backed up blood fluid from pulmonary hypertension. Anything that gets inside the tubes, inside the pipes that carry the oxygen and carbon dioxide in and out of your body, that's a problem, and that could be a cause of obstruction. Problems inside the lumen of the tracheobronchial tree, of the walls here. So people with asthma and chronic bronchitis for that matter, but especially people with asthma, they have really very good and big mucus glands from every time you get an asthma attack, these glands get to work out and they over-secrete mucus, and they get good at it. And just like a bodybuilder, if you keep exercising tissue, it can get hypertrophic, and that's what happens. And it slowly increases the size of the wall because of the size of these mucus glands. Now, a problem outside of the pipe, it could be a tumor pushing in, but it also can be this concept of radioattraction loss. And I'll save that. We have slides on that, so we'll talk about that. But emphysema is classic. And just the bottom line, emphysema destroys the parenchyma of the lung. It doesn't attack the tube itself, but it destroys the parenchyma. And when you get down to the small airways, you need the elastic fibers connecting. Let me put them back to where they're supposed to be, like the way these are. See how all these, this is the elastic fiber within the parenchyma of the lung, and it holds these tubes open. They don't have any cartilage like the larger airways do. And so if you destroy the elastic tissue, there's nothing to hold open the small airways, and they collapse. And that's also a cause of airway obstruction, and that's the problem with emphysema. Okay, kind of just talked about this, but let's hit it again. Interluminal obstruction, again, that's usually from excess secretions. Everything I explained: chronic bronchitis, asthma, cystic fibrosis. Although it's a fairly rare disease, this can definitely cause chronic interluminal obstruction. So these people with cystic fibrosis really have COPD. In fact, let's fall down the cystic fibrosis rabbit hole again. Now, we've already talked about this. We talked about cystic fibrosis effect on the intestines and the pancreas, but we haven't talked about its effect on the lung. And so I'm not going to go super deep into the cause because we already talked about that. But remember, it was called mucoviscoidosis as an AKA, which Robbins uses, so that could show up on boards, which means thick mucus. It's a deadly disease. It's a fatal disease, and it cuts your life about in half. It is the most common lethal genetic disorder in Caucasians. About 95% of the time, the child is also the child affected is white. Much rarer in people of color. It can affect many organ systems. We've talked about the intestines. We've talked about the pancreas. We've talked about the sweat gland, which is how you diagnose it, right? The child is very salty. We talked about kind of a reverse mechanism from the way it works in other organ systems, where chloride doesn't get put out. Well, we talked about that already. we haven't talked about reproductive organs, but let's talk about the lung, because that's the number one cause of death in this type of disease is from lung disease. So almost all deaths related to cystic fibrosis are because of its involvement with the lung tissue. And it's not cystic fibrosis in and of itself that kills. It's the sequelae of cystic fibrosis. Remember, we haven't really talked about it, but we will. Cystic fibrosis, in all of these diseases, except for the sweat glands, cystic fibrosis causes problems with mucus. And mucus gets really, really thick because it can't be hydrated and thinned out. So mucin needs water to bind to it to form mucus that is manageable. And people with cystic fibrosis, they can't hydrate it, and it gets so thick. And in the case of pulmonary cystic fibrosis, it wrecks the mucus escalator. A mucociliary escalator is destroyed, which is the same system that's destroyed by chronic smoking, although this one's even worse. And if you destroy this mucus escalator, you can't get normal bugs out of your lungs that you breathe in. And therefore the bugs multiply and they get into the walls of the tracheobronchial tree, and they multiply, and a wicked infection occurs, and now you got yourself pneumonia. And that's what most of these people do die of with cystic fibrosis. All right, remember the cause of cystic fibrosis. There's a bunch of causes and categories we talked about before, but the bottom line is the most common cause is a mutation with the delta F508 gene, which is a member of chromosome 7. What does delta F508 do? It makes, or it helps make, CFTR channels. And those are that long word, right? Cystic fibrosis transmembrane conductance regulator channels. I think I'm just going to call them CFTR channels. I don't know how boards are going to do. You should know that. I expect you to know that word. But recall, these CFTR channels are really important for allowing water to get into the lumen of mucus glands and thin out that mucus that they're producing. All right? If it's broken, then there's no mechanism to dilute the mucus, and that's going to lead to a mucin-heavy mucus, which can clog up the gland. It can clog up the main bronchial airways, the small airways, and lead to all sorts of trouble, including mucus plugs, where you get atelectasis in addition to chronic pneumonia. So all kinds of problems. It also clogs up the pancreas. We talked about that. And just here's a little cartoon of it again. Here's a CFTR channel created by, in the nucleus. The components for this are through the central dogma are made through the delta F508 gene. So if you have a mutation in this gene, you can't build this. Remember, we actually explained more specifically that you actually build it and it would work, but the trouble is when it goes through quality control through the Golgi tendon, through the rough endoplasmic reticulum is where it goes through the quality control system. Because it's not folded right because of this mutation, it's destroyed, which is a shame because it would still work, but it just never makes it into the membrane. Very few of them. It doesn't work full power either. Anyway, normally, so here is the lumen of a small bronchiole, and we've already we can draw, let's say we'll draw a mucus gland over here. They can also be in the tubes of mucus, the lining of mucus glands as well. This picture's kind of a little off, but we'll say mucin is made here, this green stuff, but it's super thick, but that's fine because the CFTR channel, its job is to pump chloride ion into the bronchial lumen. And then sodium follows chloride like a puppy dog, and we know water follows sodium like a puppy dog, and there's what we need to hydrate it. So therefore it's thinned out. So that's what normally happens, but if you knock out that, and you knock out that, you have mucin, almost raw mucin floating around, which is like fly paper, and that's no good, right? So, yeah, so it destroys the mucociliary escalator. Bacteria and debris can't get removed. Infections happen all the time. These patients are in the hospital once a year, sometimes twice a year from pneumonia. And the pneumonia, every time you get pneumonia, it scars up your lungs, so you're losing lung function every time. And yeah, you can get atelectasis as well from plugs, mucus plugs, which I could have added in here. Also, so it does narrow the tracheobronchial tree with the passage of time. So there's part of the obstructive lung disease. Right, so here's the cartoon. So there's a mucus gland. This is lined. This is more accurate. This is lined with CFTR channels. So mucin is actually secreted in here, but so is water. A chloride, then sodium, then water come, and they make this a manageable, more manageable mucus that comes out. There's also CFTR glands here in the cilia, or in the mucus lining as well. But remember how this mucus escalator works? Remember, there's 2 layers of mucus. There's a really sticky layer of mucus up here, which has a higher mucin to water ratio, meaning there's way more mucin than water. It's super sticky. It traps bugs. Here's we could say it's SARS-CoV-2. How about? Yeah, let's trap that one. And it's stuck. The mucus underneath, that's called the gel layer. The mucus layer underneath is called the sol layer. That's this layer right here. And that is thinner, so the mucin to water ratio is lower in this layer. Therefore, the cilia, it's still thick enough to attach this thick gel layer, so they're stuck together. But it's thin enough that the cilia can still rhythmically sweep this whole mess out of the tracheobronchial tree and into the larynx. And then you have the choice of coughing it up easily, spitting it out, or swallowing it, right? This is new this quarter, so make sure you know this mucin to water ratio is in the gel layer. It should normally be high, and the mucin to water ratio in the sol layer should be lower. So in people with cystic fibrosis, the sol layer is affected. The mucin to water ratio is way too high. In fact, it might be the same as the gel layer, and that's no good, because if this is too thick with mucus, it can't sweep anywhere, and it just sits here, and it builds up, and it even gets thicker as more and more of this mucin comes out, and it starts to narrow the airway. Okay, pulmonary edema is another interluminal obstruction that can occur. It's usually with left heart failure is the main cause of pulmonary edema. But if you have beaver dam in the left heart, it increases the pressure in the microcirculation, just like a beaver dam would upstream. The lungs would be upstream from the heart, and you start getting blood fluid. There's no interstitium. You just pour blood fluid directly into the alveoli. There's a tiny interstitium between, but the alveoli get start, and that respiratory unit starts getting filled up with fluid, and therefore you have an obstruction that way. Remember, we talked about cor pulmonale, how that can how it can wear out the heart if you can't move fluid through the blood. I've said that like a million times. But cor pulmonale, remember, it would come from COPD. It has to be a lung-driven disease. Left heart failure does not cause cor pulmonale. It's kind of a play on words. Left heart failure is the number one cause of right heart failure. But you can't say cor pulmonale. Cor pulmonale means the cause of the right heart failure is from the lungs. Right? So here's a nice, cool picture of the microcirculation. So this is the respiratory unit. of the lungs, as we've discussed in that video that you should go watch if you don't know what I'm talking about. But yeah, so blood is being oxygenated here, and it's flowing back through pulmonary veins toward the heart. And what if the heart is failing? Well, you get a backup of all this blood, and you still got the right heart pumping. I guess the right heart would be coming from here. Right heart is pumping blood in, and you got to increase pressure because of the beaver dam. And so this spills blood fluid into the little alveolar sacs here. Not good. Right? So there's the cartoon of this, and you can see blood fluid is in here, and now we got the airway obstructed. Right? How about another thing that could cause interluminal? We're still talking about the causes of obstruction. Well, you could have a physical block, or you could have a tumor growing in here as well. But a physical block, maybe somebody like this little person swallowed a jelly bean, a kind of round piece of metal from some kind of project they were doing. The dad was doing a project with these little round jelly bean pieces of metal, and the little kid, you can tell it's a little kid, right? Look at the piths aren't fused here. They swallowed it and went down the wrong pipe, and they choked on it, and now it's stuck. And so remember, this would cause, what oscillatory sound would this cause from lab? It would cause stridor. I expect you to know that. Stridor. I think I took those out. I'm not going to repeat those. But I'm just going to mention them here. Remember, stridor is very similar to wheezing, but wheezing is an expiratory sound that is a musical sound about 440 hertz. Stridor is also a musical sound at 440 hertz, but it's heard during inspiration, right? Wheezing is heard during expiration. Make sure you know the difference between those. Okay, what about intra-airway obstruction? Well, we talked about that. That would be a thickening of the tracheobronchial tree, or of the bronchial walls, which are filled with smooth muscle. So asthmatics, chronic asthmatics, have mucus glands that are thick. They also have that smooth muscle is just very, very muscular from being worked out all the time. I think it's garbage day out there. It is garbage day, but I didn't think they'd come this early. Anyway, so if you get a chronic burliness or hypertrophy of the smooth muscle and the mucus glands, it's going to narrow it's going to thicken the wall of the tracheobronchial tree, and that'll decrease the diameter. So you have an obstruction that way, right? Can be seen in asthma and chronic bronchitis. Chronic inflammation of the airways. We talked about that. Causes scar tissue after each inflammation, whether it be from pneumonia or for whatever. That can also thicken up the walls. Typically occurs with chronic bronchitis and asthma as well, or with a viral infection or bacterial infection. Peribronchial obstruction, so this is outside. So we talked about the loss of radioattraction can cause a collapse from the outside of the small airways, or you can have a tumor or a huge aneurysm, or lymph node enlargement can compress the pipes of the tracheobronchial tree from the outside. What do you think of this person? I get some water here. Well, they have cornomas, right? And they're having trouble breathing because this one more than the others is compressing some pretty large airways, and that's a form of airway obstruction, and it's chronic until they have them removed. Loss of radioattraction we talked about. It's the small airways. Again, they don't have cartilage like the big airways, like large bronchioles or bronchi or main stem bronchi or trachea. They rely on the parenchyma of the lung and the elastic tissue that is attached to them to hold them open. And so if you lose that, if you have diseases that destroy the parenchyma, will destroy the airway. The airways will collapse. So here's the kind of cartoon of elastic fiber within the lung parenchyma that is attached to the small airways and holds it open. Right? Destroy the parenchyma, as we said, in diseases which affect the parenchyma of the lung, like emphysema, and there goes your radioattraction, and there goes your small airway, and you have a tough time breathing. Right? We've seen that before. There's the destroyed elastic fiber, and the tube collapses, and yeah, the patient has trouble. That's emphysema. Okay, now let's talk about COPD. I've talked about it over the course of the program, but let's officially put it in stone now. It is a subcategory of old obstructive lung disease. It itself is an umbrella term which has two terms underneath it. There's two conditions that people always have with COPD. They always have a mixture of chronic emphysema and chronic bronchitis. Emphysema is always chronic, so it's kind of a given. You don't have to say chronic emphysema. And again, some authors more and more, like Weinstein, is including chronic asthma because it's very hard to differentiate from those. So these patients have a mix of emphysema and chronic bronchitis. It's very, very rare to see someone with pure emphysema or pure chronic bronchitis. There's always a mix of the two. It's better to say they have predominant chronic bronchitis or predominant emphysema, because the two always go together, and chronic asthma can be right in there with the mix. These are fatal conditions. They are irreversible. We can treat them. We've gotten pretty good at treating them, but they are fatal, and it's probably not the greatest death, right? Of basically you have hypoxia and die from hypoxia. Classic signs and symptoms involve hypoxia, so shortness of breath, chronic cough, especially in people with bronchitis. Chronic bronchitis is always over-secreting mucus, and these people are always infected. Exercise intolerance. If you maybe have enough to just sit at your desk or sit on the couch, but when you demand your lungs work more and perfuse the body more, you can't do it. So you have exercise intolerance. And this is a progressive condition. It does get worse with the passage of time. What about some classic image findings? Now you'll get this again when you more in depth when you get into the soft tissue pathology classes. But you can definitely get an atelectasis, which is a collapsing of the lung. We've talked about that in lab. Usually it's a reabsorptive atelectasis from mucus, oversecretion of mucus, and the mucus has completely blocked off one of the bronchi, or a bronchus or bronchi. And then the other problem is overflated lungs, where emphysema is notorious for that, where you destroy. Remember, we said emphysema destroys the parenchyma of the lung, and it also can destroy the alveoli walls themselves, and therefore you can get overinflated lungs. Let's say here is a respiratory unit, and here's an alveolar sac, and we have all these alveoli here on our little sac. People with emphysema, the disease destroys the airway, so all of these walls are disintegrate, and you're left with this much bigger sac, right? That's emphysema, another sequelae of emphysema. And on top of that, you've lost radioattraction, so these tubes get much smaller. And so can you imagine this thousands of times? You get these big dead spaces of non-functioning air. You can get air in, but you can't get air out. So you have this big air cavities in your lungs, which doesn't do anything. And therefore the lungs become overinflated because these alveolar sacs have increased so much in height, or in width and diameter. Let's fall down this. We got to talk about atelectasis a little to prepare you for soft tissue pathology. An atelectasis is like atelectasis is like cardiac tamponade. Cardiac tamponade was crushing the heart. Atelectasis is crushing the lung tissue, but there's a different type of atelectasis that we don't have in cor pulmonale, or that we don't have in compression of the heart. So we still have a space-occupying lesion or fluid. Remember, there's a cavity right here. Remember the pleural cavity? Here's the chest wall right here. There's a space between the parietal and visceral pleura. And that can start to fill up with air or blood or pus or whatever. That's going to compress the lung, and that's called atelectasis. Specifically, that's a compression atelectasis. You can also have a flat-out tumor that's smashing lung tissue. That also causes an atelectasis. Okay? But there's a new one. There's something called a obstructive atelectasis or a reabsorptive atelectasis, where you get so much mucus that it completely closes off a pipe. And it might be a small pipe, it might be a big pipe, it could be a main stem bronchi. And so what happens is you reabsorb, you suck all the oxygen out. Once this is blocked off, all the oxygen is sucked out, and you need to exchange oxygen for carbon dioxide. It doesn't fill up with CO2. It's just dead space, and it collapses. And if this happens all over the lung tissue many times over, it actually sucks the lung tissue in from the inside out. So you get a compression of the lung from the inside out, and that is a reabsorption or reabsorptive atelectasis or obstructive atelectasis. Okay? Guaranteed question on that. So make sure you know that. All right, everything I just said already. Let me just scan it to make sure I haven't missed anything. Nope. And the cause, usually these are caused from mucus plugs with chronic bronchitis. Chronic asthma is notorious for doing this as well. This can be one of the sequelae of an asthma attack. It's not only does it cause smooth muscle contraction where you narrow the pipes and you can't breathe, but it oversecretes mucus in an asthma attack, and some of the mucus can actually plug some of these smaller ducts, and you get a reabsorptive atelectasis as a result of the asthma attack. So not a good thing. There's an example. Well, you tell me, what's that an example of? I get a little more water. What is that supposed to represent? It's not drawn that well, actually. Well, that's supposed to be the pleural cavity. Let's make that bigger. So that's a fluid that's accumulated, maybe from an infection. Could be air. Maybe you got a puncture wound, and you filled this up with air. Maybe you popped a bleb. Do you guys know what blebs are? You usually don't. Blebs are little bubbles that form with many alveolar sacs together, and they can pop. And you can rupture them, and they can leak air, and you can get a pneumothorax from a popped bleb, and that can cause an atelectasis. That wouldn't be a reabsorptive atelectasis, though. Okay, 55-year-old with chest pain and dyspnea, has a long history of COPD. What do you think of this? Well, this ain't good, is it? First of all, we got too much heart tissue over here. We have hemidiaphragm way too high, right? Whoa, where's the right upper lobe of the lung? It's all sucked in and sucked down into a tiny little thing. That should be way bigger. It should be pushing the lung way down here. That's where the hemidiaphragm should be. All right, so that is a reabsorptive atelectasis from somebody who suffered a mucus plug. That's all collapsed right there. Okay, resorptive atelectasis from a glob of mucus resulted in a plug. All right, back to COPD. Some more fun facts, maybe not so fun. This was an amazing statistic from the CDC. It's the third leading cause of death in the United States. You never would have guessed that, I bet. You would have thought, I don't know what you would have thought, but cancer and heart disease, heart attack, are number one, number two, but right behind is COPD. So that's a huge problem. I think people realize that. In the United States, the prevalence of people, the population prevalence, people walking around right now, if you grabbed 1,000 people randomly out of the population, 6.4 of them would have some degree of COPD. We said it affects white people. Woody Harrelson in that great movie, White Men Can't Jump. If you have never seen that movie, that would be a great treat. Guaranteed you will love that movie. 80% of COPD deaths are in Caucasians. Smoking is another heavily related problem. Heavy smokers, 43% of people who smoke heavily will eventually develop COPD. I mean, smoking is just a horrible disease. Some people are resistant. They don't quite understand why that is. They have theories, which we won't get into. How about the classification? Now, I hesitate to put these in. I say this every quarter because these aren't true. But nevertheless, I hear they're still on board, so we got to go through these. I think you know them a little bit. But this is just not true. And Weinstein goes on and on about how this is ridiculous. But nevertheless, we have to go through these. So classically, old school wise, COPD is broken down into two types, reflecting chronic bronchitis and chronic emphysema. COPD type A, the A goes with emphysema, and the B goes with bronchitis, is how I always remember these. But classically, COPD-A is not supposed to be that symptomatic. COPD also stands for bad. This one is the fatal one. But this is not true. People die from emphysema all the time, so I don't know how this is. I don't know. Don't get me started. But I have to teach this to you. Again, it's an obsolete system. People have mixtures of A and B, so it's you can't separate these two things. And Weinstein, which is a really great, I wish our Board of Chiropractic Examiners would adopt Weinstein for this part anyway, rather than Rubens and Robbins. Weinstein goes on and on about this. This is an excellent book. Anyway, let's go through it. So A is the pink puffer. The A stands for chronic emphysema. This A and B this usually shows up in the 50s. The COPD-A, they're the pink puffers. Pink because they're still oxygenated well. It's not as bad. They're not going to die. They do get barrel chests. They're heavy smokers. They're not blue. They're not like the blue bloater. They're not cyanotic yet. That's my dragon doing weird stuff. Let me see if I can remember to get rid of that. Slide 46. I guess that's right. He's pink. He or she, they, whatever your pronoun is, they are pink because they're still well oxygenated. The cough is not a big problem. I mean, some people with COPD-A can still have cough, but it's typically not productive. It's not have a coughing attack in the morning like the type B COPD patients have. It's not foul smelling. It's white. It's not, you can't see any signs of bacterial infection. Cyanosis, which is the blue bloater, it's not typically present. So they don't have acidosis usually. These people are really skinny. This is called an asthenic body morphology or asthenic build. They may develop a barrel chest in the end phases of this, though. We'll look at that in a second. If you auscultate them, they will have no adventitious sounds. The breath sounds will be normal. Advanced, I kind of added this in here to help make this all make sense. Advanced COPD-A, they will have lung overinflation. Again, the A stands for emphysema, and we know that, as I showed you, with the alveoli coalesce, and you get these huge dead cavities of airspace, which overinflates your lungs and pushes your chest out of the normal ratio. You get more of a 1-to-1 ratio for the sagittal and coronal measures, and that's not right. You look like a barrel chest. They might, in the end phase, demonstrate accessory muscle breathing. I mean, you can see that in both types, really, but they have pursed lips breathing. You can see that in both types, too. That helps equalize the pressure and helps hold the airways. It's kind of a natural phenomenon. There's a lot of meditation practices that use this pursed lips breathing, so you can watch that YouTube if you want to see what I'm talking about. Refresher, there's a much better, healthier looking lung tissue there. Hemidiaphragm looks better. There's our Meganblas. Trousseau sign would be present in this patient. What do you think of this person? There's a 68-year-old with dyspnea. Take some radiographs. That looks terrible, doesn't it? Look at the diaphragms are way down, way too low. The heart is all stretched out and skinny. Look at how lucent the bottom of the lungs are here, right? This is all dead tissue. That doesn't even work. No gas exchange is occurring here, and the chest is all stretched way out. So they have a barrel chest. This is a person with COPD, emphysema heavy, emphysema predominant, or, I mean, old school, you could say they have COPD type A. Right, everything I said. Now, COPD type B, the B is for the blue bloater. So these are, I mean, classically these people are in more trouble, but we know that's not true because people with the type A could be in just as much trouble, but I'll stick to the theme here. So these people are, type B is for bad, right? They are going to be in bad shape. They're going to become blue because of hypoxia. These are also males in the 50s. They're also smokers. These guys have a problem with a cough. They have a hacking morning cough, and the gunk that comes out of the lungs is green. It's foul smelling, and yeah, that's what they have. These are really heavy smokers. They have lost their mucociliary escalator because of the chronic smoke has destroyed the ciliated pseudocolumnar epithelium is gone, and that's the cilia is the mucociliary or the mucus escalator, right? It's gone. It's been replaced by stratified squamous, which is tougher. So great, the wall is happier, but you've lost your membrane, so you can't clear your throat. So you're hacking every morning. You get up, hack, have to hack up this stuff and try to get this gunk out of your tracheobronchial tree. And a lot of times you can't, so these people are infected all the time. They get bacterial infections. They can get pneumonia. This is worse in the winter. This coughing or hacking and spitting out, that's called expectoration. It's a word for that, expectorate. So they're expectorating all this foul-smelling, usually greenish in color. The foul-smelling material is called phlegm. And yeah, that's the story with them. The expectoration typically has been getting worse and worse. It started out just in the winter months, and pretty soon each year it went farther and farther into the summertime. Pretty soon it's year-round, and it's getting worse, and by that time they go into the doctor. Yep, that's the story with that. Expectoration, they develop as it gets worse exertional dyspnea, where they can't walk up the stairs because they can't oxygenate the blood very good. They're typically very heavy smokers, 20 pack years or more. Remember a pack year, I don't know if someone's told you that. A pack year is the number of cigarette packs smoked per day, like is it a 0.5 cigarette smoke per day for 20 years? That will give you your pack years. You want to kill yourself. You get up around this level of smoking. That's just not good. All kinds of cancers, all kinds of lung cancers you'll learn in soft tissue that only are seen in smokers. Not to mention Berger's disease. That's the least of their problems. So So the chronic inflammation from all these infections, I mean, every time you have an inflammatory process, it has to be cleaned up, and there's dead tissue and dead cells, and scar tissue is laid down, so you scar up the microcirculation wherever the infection was. And so that can eventually scar up the microcirculation to the point it's getting hard to push blood through the lungs because of all the scarred up microcirculation, and now you wreck the right side of your heart. And COPD type B is responsible for cor pulmonale, according to this old system. But COPD type A can also do it, emphysema, and because again, it's a mixture of these two. We've talked about cor pulmonale enough. Radiographically, these people have cor pulmonale, so they have right ventricular hypertrophy. The right heart was muscled up before it started failing. And they will, because it can't pump blood well through the microcirculation, you're going to have a backup of blood, and that's pulmonary hypertension, and that pushes some of the blood into the alveoli, so you could get congestion as some of the blood fluid is pushed into the alveoli, so that's a possibility. There are other signs. There's scar tissue you can see in the lungs, and they'll get into this in soft tissue. You can see nodules from this. We've already talked about right axis deviation, right, because of the right ventricular hypertrophy. How would that look on an EKG? I took a bunch of slides out because I'm not going to teach you that again. We're already responsible for that. But you better know what a right axis deviation looks like. All right, here's a patient with severe COPD type B, chronic bronchitis, and the heart is kind of rolled over, so the right ventricle is now sticking out here. You can see the right atrium is really hypertrophic, and the lung fields are all scarred up, right, from congestion and scar tissue. Not a good thing. And then in the moderate to severe cases, this is where the blue comes in. How do you do gas exchange through this? You don't do it very well. You can't get the CO2 out of your body. If you can't get the CO2 out of your body, you can't reabsorb acid, and your blood starts becoming acidic. So you get respiratory acidosis. So COPD B patients get hypercapnia, which is too much CO2. And if you have too much CO2, you have respiratory acidosis as well. And then auscultatory sounds, because of the fluid in there, just like with pneumonia, you'll start to hear crackle, snap, crackle, pop. So make sure you know that. All right, remember this physiology thing? I like to throw a little physiology, see if you remember anything Dr. Doe taught you. But normally, CO2 travels in the form of HCO3, right? And bicarbonate combines with hydrogen, and it kind of hangs out here in the blood. This is what we don't want, right? But you can combine it to make CO2, hydrogen. If you add a hydrogen ion to bicarbonate, you get carbonic acid, right? And carbonic acid can be metabolized or broken into CO2 and H2O. So you make carbonic acid, break that down into CO2, H2O. CO2 can diffuse out and exchange for oxygen here. Remember, this happens a little bit in the blood. Most of this happens in the bloodstream, where the hydrogen ion and, I might as well just call this carbonic acid, right? Because these two are bound together. So hydrogen ion travels as carbonic acid, which is acid. And you need to get rid of that acid. So how do you get rid of it? You turn it into water, basically. Take carbonic acid and turn it into water. That neutralizes the acid, and it makes CO2. Mainly happens in the red blood cell via carbonic anhydrase. All right, so let's get into asthma. These patients have sporadic attacks. It varies in numbers. The more severe your asthma is, some people have asthma attack once a year, once every 5 years. Some people have it once a month, 3 times a month, 5 times a week. It can be really bad in some people. but they come as attacks with the tracheobronchial tree goes into spasm and you can't breathe. You get an overproduction of mucus, which makes things worse. You could get an atelectasis after the attack is gone or during the attack as well. And it can dangerously hinder a person's ability to breathe, and they can die from asphyxia. Right? It's a nice little cartoon of someone having an asthma attack. And normal airway is, after the attack, they're fairly normal. Now, the worse you have asthma, if you really have asthma 3-4 times a week, your lumen's going to be more compressed. And as your life goes on, it gets more and more compressed as the smooth muscle becomes more hypertrophic. So a little more explanation of that drawing needs to be made. But during the attack, it's the same. You have tons of mucus, and the airways are in spasm, and not a good thing. It's a very scary thing. It is the most common chronic childhood disease in developed nations is asthma. Look at this number. 8% of children and adults are affected by the disorder. There's no cure for it. African Americans have a higher death rate from the disease from other races, and we don't know why that is. About 50% of it seems to be related to genetics. So if mom and dad have asthma, you have a pretty good chance of getting asthma yourself. The other 50% is from the environment, whether or not you're allergic to environmental or even non-environmental factors we'll look at. What's the pathophysiology? All asthmatics have a airway, specifically have smooth muscle in the walls of the airway that are hyper-responsive. They overreact and go into spasm from contact with something where they shouldn't. It could be allergens like cat fur, or it could be non-allergens like exercise. Yeah, as crazy as that sounds. But normal people don't react, they react. And when I say react, their airway goes into a spasm because of the smooth muscle in the wall. Submucosal glands also overreact. They have really big, especially people with really bad asthma, they have large submucosal glands, more correct term for that, and that can actually narrow the airway. We talked about that. Okay, when the attack occurs, they secrete tons of mucus. We talked about that. During the attack, they overproduce IgE, immunoglobulin E, and we know that this is an antibody which stimulates anaphylaxis, and it triggers the release of histamine from epithelial cells, which causes them to shrink, and it's really easy to get blood fluid leaking out of the microcirculation of the lungs when histamine is loose, right? And then you start getting fluid in your alveoli from this. And that's not a good thing, right? You're already having spasm of the microcirculation, and now you have fluid in your lungs. The overproduction of mucus from the submucosal glands can make mucus plugs, which can occur during the attack or after the attack. And you can get a reabsorptive atelectasis that occurs, hours after you think you're out of the woods. What are some risk factors for developing asthma? Definitely a positive family history just in and of itself. I could have just added that on 72 by itself, just family history. Your mom or dad had asthma. Right? Let me actually put a note to add that in there, 72. I did. Positive family history for asthma, I'm good. Or atopy, it should be a separate category. So if you or mom or dad are atopic, what does that mean, atopic? That means that you are allergic to everything under the sun. You have hay fever, spring fever, you're allergic to everything, cats, you're allergic to dogs, you're allergic to peanuts. You just have all sorts of allergies. You have atopic dermatitis when you're a child, or maybe you still have atopic dermatitis. That is atopy or being atopic. So if you have that, you're at risk for asthma. If your parents smoked while you were in vivo, that increases the chance of asthma. Or if they're exposed to secondhand smoke while you're still developing in mom's tummy. Or if you're a smoker yourself, you're at risk for asthma. So asthmatics definitely should not smoke. Horrible, right? What is she thinking smoking when she's pregnant? That's just absolutely unexcusable. Whole bunch of genetic predispositions are known. There are genes. I cut a bunch of stuff out. We don't need to get into the genes on this. I like the Sphinx. The Sphinx 5 gene is particularly prevalent. I think they test for that now, 23 or me or whatever those tests are. DPP10, GRAPPA-A, those are common gene mutations associated with asthma. Again, immediate family history for asthma greatly increases your chance. Having viral infections, having viral pneumonia when you're a kid seems to increase the chances as well. Pre-existing inflammation. So this is relatively new, but the real pathophysiology is not understood for asthma completely. There is some new research that shows, we keep coming back to this inflammation, don't we? New research shows that airway hyperresponsiveness may actually be secondary to something. Specifically, that hyperresponsive airway is caused by a pre-existing inflammation of the tracheobronchial tree. Maybe some from unknown environmental factors, maybe from some virus. We're not sure what it is. But I didn't go too far down that hole because it's not in Rubens and Robbins yet, but that's certainly a possibility. There are two types of asthma. There is non-allergic asthma and allergic asthma. Sometimes the non-allergic is called non-atopic, and the allergic asthma is called atopic. Make sure you know those AKAs. There are some really complex classification system, but even the Lancet, which is one of the greatest journals in the world, that and the New England Journal of Medicine are the top two in the world. They really kind of wrote a bad piece about how ridiculous some of these classification systems, and keep it simple. Allergic versus non-allergic is a good way to categorize these things. All right, so let's look at non-atopic asthma. These patients have asthma attacks without any allergen. So there's no identified allergen. They get tested. We don't know an antigen or allergen, same thing. We don't know what the trigger is. Well, we do know what the trigger is in some cases, but there's no physical thing floating in the air that they breathe in or they eat that causes this. Then we have atopic asthma. There is a known allergen. We know exactly. It's cat fur. It's, whatever. It's silicon dust. There is an allergen, and we can identify it and try to avoid it. That is the most common type of asthma. 40% of these patients also have atopic dermatitis and allergies to foods and all sorts of things. They're atopic. What are some triggers to atopic asthma? You definitely need to know these. I guarantee this really high yield board type question. You got to know these because your patient, you're going to have patients with asthma, and they don't understand it. And maybe the primary docs, sometimes they're so overworked these days, they're not so good at explaining things. So you have to explain them. You are a primary healthcare provider. This is part of your job. So pollen, especially in the springtime and in the fall time, certain pollens can do it. Animal hair, fur, which is really animal hair. I guess I could take that one out. Dust dust mites, walking into a really dusty house, or the dust mites themselves, smoke from tobacco or forest fires, things like that. Classic triggers. We'll just leave it at that. There are other types of asthma. This is kind of out of place, this slide, I think. But there are other types of asthma I'm not going to get into, but you should be aware of. There's exercise-induced asthma, which is considered a non-atopic asthma. There's a strong emotion-induced, when you have an emotional reaction to something. Just found out you got fired, you can go into asthma attack. That's also a non-atopic asthma. Cold air-induced asthma is also a non-atopic asthma. By the way, co-dates, like going on a date with somebody. Maybe you're going on a co-date with two people, I don't know. But co-dates actually fits this quite nicely. Tobacco smoke, that would be an atopic asthma. These are atopic asthmas over here. Occupational dust and fumes like silicon in our area. Drug-induced, air pollution-induced. Those are all atopic asthmas. What about the symptoms? We kind of talked about this: coughing, wheezing, expiration. Remember, a wheezing is that musical note, 440 hertz on expiration, not to be confused with that choking. Dyspnea, orthopnea. What's orthopnea? That is when you're having an asthma attack, you definitely cannot be lying down, prone, or supine. You have to be sitting up and bent forward is the best kind of tripod position, they call it sometimes. Anxiety will be going, which makes things worse. When you have an anxiety attack, it increases sympathetics, which increases the constriction of the bronchial tree. Accessory muscle. Oh gosh, looks like we lost the link. Thank you very much, Virtual Classroom and Brightspace. I'll have to put this on YouTube, it sounds. Accessory muscle respiration will be engaged. And if the attack is severe anyway, the accessory muscles will be going. What about the clinical findings of asthma? Auscultatory sounds, wheezing we've talked about, expiratory sounds will be all over the lung fields. Remember musical note 440, we talked about that a lot already. And chest radiograph will be normal unless the patient has severe asthma and it's been going on for many, many years. There may be hyperinflation in people with chronic asthma is another possibility because of just like emphysema, patients with severe chronic asthma, I mean, that's why it's part of COPD. It can destroy the alveolar sacs just like emphysema can. So you can get lung hyperinflation, but those are for patients with severe chronic asthma. Pulsus paradoxus is present in these people. And again, this would be in someone with severe chronic asthma because their microcirculation is scarred up. They have pulmonary hypertension, and you can't get blood through the lungs or out of the lungs. If you take a deep breath of air and suck blood into the right heart, the scarred up lungs hold onto the blood and you don't fill up the left ventricle enough. And therefore, during inspiration, you have a drop in blood pressure. And we've talked all about pulsus paradoxus. What about the treatment for asthma? Bronchoactive drugs are the mainstay. They're called bronchodilators. There's fast-acting and slow-acting ones. We're just going to focus on the fast-acting ones, but they prevent or reverse the effects of an asthma attack. They're administered through something called an inhaler, is kind of the norm that you take with you. There's also a nebulizer, which is actually a better way to get the medication into your airway. We'll look at those in a minute. We got to talk about some bronchoactive medication like the bronchodilators. There's two flavors. There's the beta-2 adrenergic selective agonists. Watch out. I love to trick you, put an antagonist versus agonist in here. These are agonists, so they're going to stimulate an effect. They're not antagonists or blockers. Agonists make something work at agony because it has to work, right? So the beta-2 agonists are involved here. These drugs bind to the smooth muscle wall in the airways via beta-2 receptors, and that binding triggers the reabsorption of calcium in the cell, and without calcium, the muscle relaxes and breaks the spasm. Inhaled corticosteroids are for people with more severe asthma. If you have asthma all the time, you're going to have inflammation all the time, and it can start damaging the lung tissue. So you have to fight that with the chronic use of a corticosteroid to fight that, break that inflammation so it doesn't wreck your lung tissue. Here's the albuterol is the classic beta-2 agonist, and it binds through this reaction, stimulates the release of cyclic AMP. We talked about this with Viagra, right? It stimulates PKA. PKA inhibits the release of calcium from the from the endoplasmic reticulum, and you get a smooth muscle relaxation, which equals bronchial dilation. Who are the short-acting bronchodilators? Albuterol, you definitely need to know that name. Levobuterol is another one that's used, so make sure you know those if you don't already. These are the ones that are used in those little portable rescue inhalers most of the time. They're called rescue inhalers, those little portable things, and they treat attacks. Sometimes I see some professional athletes need to do this before they on game day and during the game. They have exercise-induced asthma, and to keep it at bay, they need to keep albuterol, this smooth muscle relaxer, in their system. When do you bring out the big gun? When do you bring out corticosteroids? So corticosteroids, again, are used to fight inflammation and its negative sequelae of damaging the microcirculation. The rule of thumb is if you have to use albuterol more than twice a week, then you should be on corticosteroids as well. And there's different theories behind that. That's kind of the general rule of thumb. All right, so therefore, just beta-2 antagonists like albuterol are used for run-of-the-mill asthma. People with more severe asthma, where they have 2, 3, 4, 5 attacks a week, they should also be on a steroid to prevent lung damage. Right? There are some, now when we talked about this already, we talked about long-term use of corticosteroids. This is just like taking prednisone. So you're going to have those same effects. In children, it can actually decrease the growth, impair growth in children, decreases bone density, causes skin thinning, cataracts. It suppresses the HPAA axis, right? So you can have trouble when big stress occurs because your own HPA system is turned off, and you can't produce your own cortisol when you need to. When you have a big stress event and you need to make more cortisol, you can't do it because your HPA axis is shut down. And so, yeah, the same kind of stuff there. I put some students, for whatever reason, got in their head that people don't need to be on medication because chiropractic care can be substituted for albuterol and steroids. Absolutely ridiculous. And here, just to prove to them, I had to put this in here. This is from a chiropractic journal, did a systematic review on the literature, and they chose 8 randomized controlled trials comparing chiropractic to medication. There was no, the chiropractic didn't work. You can't substitute chiropractic care for albuterol or for those more severely affected for steroids. You'll ruin the patient's lungs. So don't try to think you can do that. All right, there's a good movie. You want to watch a scary event. Horrible bedside manner with this doctor. She needs to not act like this. But anyway, there's a good YouTube video on someone having an asthma attack. All right. Again, sorry. I wish I could have been there this quarter to lecture in person to you, which is always better than this. But I hope you got something out of the course. I'm sure you did. And we will see you in 7th quarter, hopefully, when I will be back lecturing as normal in person. See y'all later.